Toothwear is a widespread condition with several contributing causes. We usually describe it in 4 categories: erosion, attrition, abrasion, and abfraction. Recognizing each type is essential for diagnosis and prevention. Erosion is chemical wear caused by acids. These may come from the diet, like frequent soft drinks, or from the body, such as reflux. Early signs include shiny flattened enamel and small cupped lesions. With progression, palatal surfaces can thin and teeth may shorten. Preventive advice is effective. Limiting acidic exposures between meals, rinsing with water, delaying brushing after acids for at least 30 minutes, and seeking medical care for reflux all help slow progression. Attrition results in tooth-to-tooth contact, usually in people who clench or grind. It produces flat, regular facets that match opposing teeth. Management focuses on recognizing bruxism, reducing contributing factors such as stress, and protecting the dentition with occlusal splints. Abrasion occurs when teeth are worn by something other than another tooth, most often toothbrushing. It typically shows as notches near the gum line and often combines with erosion. Patients benefit from advice to use a soft brush, avoid excessive force, and stay away from abrasive pastes or using their teeth as tools. Abfraction is thought to involve stress and flexing forces at the neck of the tooth, creating wedge-shaped lesions. The scientific evidence for this is less strong, but a pattern is often included when we classify wear. These lesions are generally managed preventatively, with restorations only when they cause symptoms or compromise the tooth. Prevalence studies suggest that between a third and over half of adults show visible tooth wear, with a smaller percentage, around 1 in 10, having it severe enough to need treatment. It increases with age and is more common in men. The biological impact is usually small because teeth adapt well, and pulpal damage is rare. What matters more is the effect on appearance and confidence, which may affect quality of life. Progression depends on risk factors. Clinical trials have shown that reducing dietary acids between meals can cut wear progression dramatically, while reflux treatment can also make a measurable difference. To record and monitor wear, indices such as the Basic Erosive Wear Examination, or BEWE, are recommended. These allow clinicians to grade severity and track change over time. I'm now going to run through how to use the BEWE. The mouth has 6 sextants. In each sextant, you must score the most affected tooth with a score of 0 to 3. 0 presents with no erosive tooth wear. 1 presents with initial loss of surface texture. 2 presents with a distinct defect involving less than 50% of the surface area. 3 presents with hard tissue loss, involving 50% or more of the surface area. The total number of all the sextants indicates the level of tooth wear the patient has. As you can see in the table above, there are 4 levels of tooth wear: no erosive tooth wear, low, medium, and high. The general guidelines for management for each of these scores is indicated in the table. Management should always start with prevention, and treatment is driven by the patient's concerns. Restorative intervention is usually reserved for cases where function or aesthetics are significantly affected. The key message for clinicians is this: identify the type of wear, assess the risks, record findings, advise prevention, and intervene only when the patient's quality of life is compromised.